Bismillah ar-Rahman ar-Rahim. Now we are going to discuss the chronic type B aortic dissection. The chronic type B aortic dissection is very important topic. Usually the aortic dissection is defined as chronic when it crosses 14 days. So at 14 days, 2 weeks, it doesn't become acute. It's called chronic. But sometimes there is a new name which is called subacute. And this caused a lot of confusion to a lot of vascular surgeons. So subacute is between 2 weeks to 3 months. Between 2 weeks to 3 months, it's called subacute. We know that 70% of the deaths from aortic dissection happen within the first 2 weeks of onset. So at the first 2 weeks, you get 70% of the mortality. The other 30% will be either in the subacute or in the chronic phase. And this is very important. Now, the growth of thoracic aortic aneurysm is very important to know, and this is between 1 millimeter to 7 millimeter per year. Obviously, when the growth is more toward the 7 millimeter, the more it will be dangerous from rupture. And hypertension should be aggressively treated and aggressively managed. Management of chronic type B aortic dissection. Number one, and we couldn't emphasize more, is aggressive medical treatment. And we know that beta blocker is very well known to be very effective in this stage. So this guideline showed that beta blocker did show a quite high efficacy in controlling hypertension with chronic type B dissection of the thoracic aorta. That is why in the guidelines they will mention that beta blocker, as you can see here, beta blocker should be given to patient with chronic complicated aortic dissection. And this is very important point. And if patient does not improve on the best medical treatment, then you are obliged for repair. The first option is endovascular repair, and the second option is operative repair. And this guideline showed, although it is 2017, but it did mention some endovascular repair options. Of course, it has dramatically improving over the 5 years after that, and this is the corner of these guidelines from 33 to 35. And you can read them, and it mentioned that the aortic dissection between 56-59 millimeter may be considered an indication for treatment with a patient with reasonable risk. So this is the first time to speak about certain diameters that should be starting to treat. And we did mention before the normal diameter of descending thoracic aorta. Obviously, it's going to speak about operative repair, and you can see here is the operative repair. And in operative repair, the mortality risk is variable between 6 to 11%. According to which center, how many cases they do. The operation of chronic dissection is very similar to the operation of thoracic aortic aneurysm repair. The same tools and same precautions and same complication. So they are the same. And here is the two important guidelines, number 36 and 37, and they speak about the operative repair, open repair of aneurysmal symptomatic chronic type B dissection in patient with low surgical risk should be considered dedicated center with low complication rate. And this is quite logical. If you are young and fit with a high quality, high flow center, operative repair is recommended. And in patient with chronic type B dissection undergoing operative repair, intraprocedural cerebrovascular drainage and left heart bypass and moderate hypothermia should be considered to reduce. So these are the elements that nearly becoming now as routine practice. Here is very important paragraph to remember, which is indication for endovascular repair. If the diameter is 60 millimeter, it carries an annual risk of rupture of 10%. So the threshold of 70 millimeter at which risk rupture suddenly escalate. So intervene in the thoracic aorta at range of 55. It is same like the aorta, 5.5 in the abdominal aorta, remember this. And the threshold can be reduced 50 to 55 for women. Women always smaller than men and have their own statistics. Now, open repair, if any thoracic aneurysm below 50 millimeter, it is not worth performing an operation at all because you don't get any survival benefit. Now, open repair comes second if you don't have adequate arterial access, if you don't have proximal and distal landing zone of 20 millimeter, and this is why the guideline of 38 and 39 are very important to read, explaining this risk. Now we're going to speak about the aneurysm. So discuss first the dissection. Now the aneurysm, it is similar in the definition of the diameters, and the management is also similar with an advantage of the endovascular options rather than the open option. But open options are there. And here they collected the guideline regarding aneurysmal repair. I will go through them quickly. They speak from the guideline 40 to 44B that CT angiogram is the standard practice to preoperative assessment of a patient, and in contraindication of open surgical repair, you should investigate coronary artery disease. If you have a lesion, correct the coronary before you go to this operation to withstand the stress of the procedure. If you have asymptomatic coronary artery disease, should be considered. So if you have asymptomatic stenosis in left coronary or right coronary, you should be treated before you indulge in open surgical repair. Open repair considered if you are a fit patient with descending thoracic aneurysm between 55 to 59 millimeter diameter, and smaller obviously in women. And this is these guideline what to speak about, which is all now quite a standard in practice. Now, one of the very important diagrams that you should be fully aware is this diagram, which is Crawford classification of thoracic aortic aneurysm, descending thoracic aortic aneurysm, with modification of Hazem al-Safi. And remember, Hazem al-Safi of Iraqi origin, but he worked quite a lot in the United States, and one of his eminent registrar is Professor Samer Qusayr. So type 1 start immediately after the left subclavian artery, and this is type 1 Crawford. Type 2 Crawford again start in immediately after the subclavian artery or anywhere above T6 vertebrae, which is crucial for the paraplegia, and continue until the bifurcation. This is called type 2. Now type 3 start after the transverse thoracic vertebrae 6, T6. After T6 and extend to bifurcation, and this is a Hazem modification, which is type 4 and type 5. You can see type 4 below the diaphragm, involve all the visceral vessels, and the type 5, which start after T6 but above the diaphragm and continue until the renal after that. So this you should memorize very well. Crawford classification, and it's a lot better to know little bit about Crawford, who was a cardiovascular surgeon, very eminent in United States, and developed a lot of cardiovascular procedure and played part in artificial heart as well. And also you should know about Hazem Safi, which is the main one to have the least paraplegia rate in thoracic aneurysm repair. And this is important for you to know. Now, you obviously is not going to be asked about the exact steps of descending thoracic aneurysm repair, and because this exam is for first day vascular consultant, and this is not one of your duties, but at least you should know the guideline related to open repair and endovascular repair. So in endovascular repair, you can see here between 48 to 52 recommendation. All of them speak about endovascular repair, that you should do pre-operative cardiac, pulmonary, renal, and this apply not just for thoracic but also for the aorta. In type 1, 2, 3 thoracic abdominal aortic aneurysm surgery, extracorporeal technique allow the distal aortic organ perfusion, and you must know tools like octopus and blood transfusion. That's why it need to be done in a special center, usually tertiary referral center. Patient with extensive thoracoabdominal aneurysm type 1, 2, 3 undergo open repair. CSF fluid drainage should be considered. Again, we mentioned that, plus hypothermia. And again, the centralization of open repair aneurysm descending aorta may be considered, and I think this is very beneficial. Centralization of services, especially in these difficult cases, is a lot better with better results. Now you should know Takayasu arthritis. And this is very important. Takayasu was a Japanese ophthalmologist, and this is called the pulseless disease. And you don't get any radial pulse, very small arteries in the aortic arch. And important for you to know little bit about Takayasu, to know the clinical picture, and to know the criteria of diagnosing Takayasu arthritis. Here are the 6 criteria of diagnosing Takayasu. They should be marked. I will mark them. I did mark them, so this is very important for the exam. You should be able to remember these 6 criteria of Takayasu arthritis. Again, giant cell arthritis is very important for you to remember because it comes into the exam, especially with the histology of giant cell arthritis. And the etiology of the giant cell arthritis is unknown, but the pathology is similar to Takayasu arthritis, including T lymphocyte, the structure of the elastic lamina, T cell clonal expansion is also important. Clinical presentation, usually fever of unknown origin, and then you get a giant cell arthritis, and sometimes we diagnose that by temporal artery biopsy, and we send it for histopathology. One of the important topic is Behçet's disease, and this is important, especially if you're going for MED exam in Egypt, because it is common in Egypt. And Behçet is a Turkish dermatologist, as Takayasu was ophthalmologist, and he discovered in 1937 the syndrome of Behçet disease. Vascular malformation, you get multiple aneurysmal dilatation, multiple areas, multiple arteries, multiple presentation, and this is important for you. Here are specific guidelines regarding the arthritis episode. and they are very, very nice, because here you can see the guideline number 56 is that corticosteroid should be started if you diagnose inflammatory disease into the aorta. And it also mentioned selective repair in thoracic inflammatory disease, and obviously suture and stitching is very crucial to these patients because they have a connective tissue disorder and inflammatory disease as well. Patient with inflammatory disease of the descending thoracic aorta undergo surgical intervention, apply a higher dose of corticosteroid, and always don't operate on arthritis in the active stage. Let it settle down with a corticosteroid, maybe immune suppression, and then ready for intervention or open repair. One of the nice things about this paper, they mentioned the controversy of the thoracic aneurysm. There is a lot of controversy. Some of them has been answered by the other guideline, the more recent one. Some of them are still not very clear. But I wouldn't go through them because I recommend you to read the Aortic Guideline 2024 because they answer a lot of them. And this is some of the genetic syndrome. I will mention Marfan because Marfan can come as a long vascular case for you. So you should know Marfan syndrome, which is hereditary disease, a mutation of fibrillin FBN1 gene on the chromosome number 15, and this is the cause of Marfan syndrome. You need genetic counseling of the family to know if it's going to happen to the offspring or not. You need to estimate that 1 in 3,000 to 5,000 individuals have Marfan syndrome, and you need to know symptoms and signs of Marfan syndrome, flexion of the finger, hyperextension of the neck. All these are very important for you. One of the important diseases also is Lloyd-Dietz syndrome, and this syndrome, LDS, is autosomal dominant gene caused by mutation of gene encoding transforming factor beta receptor 1. Unfortunately, you have to know this. Encoding of the cross factor beta receptor 1, TGF R1 and TGF R2 for Lloyd-Dietz syndrome, and some of the patients come to the clinic already diagnosed with this syndrome. And the main characteristic of this disease, like we mentioned, arthritis, here arterial tortuous, more often the vessel of the neck, especially the carotid. They usually have hypertelorism, widely spaced eyes. This is specific for Deutsch-Reed syndrome, so you can diagnose by looking at the face. A split broad uvula, so this is why you inspect the mouth and throat for patients with aortic aneurysm. And aneurysmal dilatation. There is a lot of cardiovascular involvement as well, and you need to really read all the description of Lenz syndrome. Ehlers-Danlos syndrome is a syndrome or group of disorder with the common feature of bruising, joint hypermobility, skin hyperelasticity, weakness of tissue, including arthritis. I remember a patient was booked for varicose vein surgery, and she was known to have Ehlers-Danlos syndrome. It was the first time for me, and when I just dissected great saphenous vein, it came off the femoral vein, and bleeding was heroic. So Ehlers-Danlos syndrome, if you have patient, please don't do surgery unless you really have to, or unless it is an emergency. There's also you need to have a quick look at the familial thoracic aortic disease, which is also important, sometimes come in the exam. And aortic tumor, just mention very few that they are very, very rare to get aortic tumor, but sometimes when you see a lot of cases, you get aortic malignancy. These guidelines explain the genetic predisposition. Again, they are nice to read, and they are give a light about the genetic predisposition of aortic disease. Now, they end the This guideline was very nice topic, which is called the floating thrombus. Floating thrombus is an important topic because it's a mobile thrombus in the descending thoracic aorta. Sometimes it comes in an exam in a long case, what to do. Floating thrombus in the aorta is rare event, usually associated by underlying blood disease like thrombophilia, and many cases are pathological. Some of them it can be tumor thrombus. Prompt diagnosis by CT angiogram, transesophageal echo is important. Treatment strategy, there are a lot of controversy, but anticoagulation definitely is we all agree about the best medical treatment, and you can do endovascular aspiration if it is symptomatic or if it is in dangerous place. There is what is called EndoVac, which EndoVac is a big device, 26 French, and can have thrombus from the aorta. Or if it is very quiet place and patient asymptomatic, you can follow up with very frequent visit, irradiation. But I really don't like to wait on a patient with floating thrombus. Not really advisable unless you have to or you don't have much option. Here are suggested disease-specific protocol controversy. So this is extremely important schedule. What are the CT scan criteria or MRI if you think of acute aortic disease, if you think of intramural hematoma, if you think of patent aortic ulcer? And this you need to memorize it by heart. You need to memorize it by heart. And if I would say the best schedule in this recommendation is this schedule. And it has not been changed over the last 5 years. It is the same. Inflammatory disease, you need cut section 3 millimeter, 6 millimeter, and you need to do it 3 months, 6 months, and yearly. All the cut section are 1 millimeter cut section. In critical situation, critical landing zone, you can go up to 0.5 millimeter, and this is the follow-up. You can see if you don't remember very well, then you pick up 3 months, 6 months, and yearly, because this applies to most of them. And this is the last of the guidelines, which reaching 80, which is the last guideline. I will just mention the last one. In patient with descending thoracic aneurysm pathology managed by open repair, follow-up imaging 6 months with CT angiogram is performed. I hope with this I have summarized to you the thoracic aneurysm guidelines. It shouldn't take 3 hours for you to study it very well. Probably 2 hours is sufficient for you to memorize it, important point. And then you need to mark your own copy. And then after that, before the exam, you can shuffle through, know exactly, and it will help you a lot in clinical cases and to prepare yourself. I hope it was of benefit to you. I wish you all the best and see you in more recent guidelines. Wish you all the best.